Greetings, everyone, and welcome to day 3 of the 9th Multi-Country Network meeting for the Southeast Asia Stigma Reduction QI Learning Network, led by UCSF HEALTHQUAL and made possible with support from Gilead Sciences and ViiV Healthcare. My name is Charlie Ferrucci, and I am the program manager at HEALTHQUAL, and I am honored and excited to welcome you all to this virtual session. I'm joined by my team at HEALTHQUAL, Bruce Agins and Richard Burchard. This meeting is also coordinated with support from our UNAIDS colleagues, Quentin Laterre and Belize Adamna, as well as Harry Prabowo from the Asia Pacific Network of People Living with HIV. At this time, I ask that you please introduce yourself by writing your name, affiliation, and country in the chat box. And if you have a mental health role, please specify that. Throughout the meeting, if you have any questions or concerns, please direct message me privately via Zoom and I'll be happy to assist you. To recap, across day 1 and day 2, we had over 150 unique attendees join us to hear from our country teams and esteemed guest speakers. We thank our country teams from Cambodia, Vietnam, the Philippines, and Thailand for their presentations on their recent stigma and discrimination efforts. During day 1, we were joined by Dr. Nitya and Greg Carl from the Institute of HIV Research and Innovation to hear about the innovative KP-led health services model, where task shifting allows for KP lay providers to deliver a package of services that are needs-based, demand-driven, and client-centered. On day 2, we had the pleasure of hearing from Solange Baptiste, Nadia Rafif, and Sam Everett from the International Treatment Preparedness Coalition as they discussed citizen science, known as community-led monitoring, and the activities and impacts of their efforts. Lastly, we heard from Dr. Sunisa Sukjakal on a self-stigma program and curriculum implemented in Thailand, and attendees engaged in a breakout session focused on reducing self-stigma among people living with HIV and service delivery. Today, we'll hear programmatic updates from our country teams in Laos and Malaysia, with discussions led by Quentin Laterre. Later, we'll hear from Alex Carulian from the Fenway Institute as he discusses mental health service delivery among people living with HIV and the unique mental health needs of LGBTQ populations. We will then engage in a breakout session focused on addressing mental health issues among people living with HIV, the barriers and challenges that exist, and the development of specialized mental health interventions for key populations. Throughout Southeast Asia, there is a lack of services that cater to the specific mental health needs of key populations. Few clinical programs in the region have experienced or provide specialized mental health services to LGBTQ populations. Key barriers continue to exist to increase the pool of providers who can effectively screen, diagnose, and treat mental health and illness among people living with HIV. Noting this specific area of importance, we ask that you please stay and engage in the mental health focused breakout session to maximize the potential for learning. Again, we welcome you all to day 3 of this network meeting, and we thank you for your ongoing interest, participation, and dedication across these 3 days. On behalf of HEALTHQUAL, we applaud your tireless efforts to reduce stigma and discrimination among people living with HIV in clinical settings. The presentations thus far have proven that when we involve patients and community in our efforts and provide them with the resources they need to lead, we can create long-lasting and sustainable change that will impact service delivery and outcomes. Reducing stigma and discrimination remains a critical component to reach UNAIDS goals and achieve HIV epidemic control in Southeast Asia, and we look forward to our continued work and collaboration. At this time, I would like to welcome and pass the mic to Quentin Laterre. Thank you.
Thank you, Charlie, and good morning, colleagues. I am Quentin Laterre. I'm the Human Rights and Law Advisor for the UNAIDS office, the regional UNAIDS office in Bangkok. And very happy to welcome you here also on behalf of UNAIDS. With that, I would like to invite the colleagues from the country team of Laos to start a presentation. I think that is Kitmala Banchongpanit that will give the presentation from CHUS. So can you kindly unmute yourself and start the presentation?
Good morning.
Thank you so much.
And good evening for dear So I would like to share how S&D activity that what we have done during the COVID pandemic. The routine activities, especially for S&D routine monitoring among the healthcare worker and by quarterly has changed to twice a year. So the internal meeting on S&D issue and challenge was paused. At the ART side, some ART side staff has to shift to the COVID-19 treatment team. So we laid off the staff. For quality improvement in with psych coaching also was the pause because of the restriction of the travel. So, but however, for the routine monitoring for the S&D, we still continue with, and we collect the data in July, and also we add that additional in this round. Next. So for the 6th round, we use the Google form to ask that the healthcare worker is more easier to control them, and also that to collect the data and analysis. Next. This is that in the Google form that we use is. So could you yes, so for the 6th round, we has the 1,600 healthcare workers to respond to the 8 questions. So but I think at this time that we get more respond to the question, that healthcare worker is involved more in, if we compare to the 5th round. Okay, next. So we continue to do the survey with the same word, and around the 15 word, and 70% were nurse to respond to this to the questions, and then that the doctor is about 29% that to respond this. Okay. If we compare to the 5th round, that I think that the percentage of the wearing the double cloth less in the lower, I think is better there. So on almost the of the question is lower. I think it might be the doctor or nurse or healthcare worker is understand more, and that they get the more information and knowledge for that. Okay, next. And this also that for 6th round, that the attitude of the healthcare worker is, I think is getting better. So if compared to the fifth round. Yes, next slide. So in is here that show the in detail of the worry of the getting that drawing the blood from the PLHV. I think that the most worried is the midwife that working in the labor room, so that, and also the dentist that is on also that they are worried about that PLHV. Next, please. That wearing the clothes, I think that and the midwife is still high, but usually that in the labor room, so that if they follow the IC, that the infectious control, that they usually they use the 2 cloth for the do the service. I think is not how to say that is not they are worried, but it is their duty that to wear the 2 cloth. Compared to the typical that avoids physical contact to the PLHV, that is we select from the 11 ART site. See, but some site is still high, so but some site is no how to say that is very good is 0. You can see that the side 3 that 0. So, but in totally that we still have that the 10% of the avoids the contact to the PLHVs. Yes, and also that is here the side 5, that ART side number 5 is still high for the wearing the cloth, double cloth, but totally is 6%. 6 is compared to the 5th round. I think is more less than the 5th round. I think it's getting better. Draw blood from the patient living with HIV. So if we look at this, so still high in so many ART sites. So totally is 24%. So I think that we need to so this data we not feedback to the ART site yet. So we plan to give the result to the and feedback to the ART site to have the plan for the advocacy, or to do the meeting with the healthcare worker in the ART site. So is near the patient feedback. So if we that we have done in fourth round. So if we compare to the 3rd round, that the number of the PLHV response is less than because of the COVID-19, and so that and restriction of the travel. So patient is most are not able to come to visit the doctor. Next, please. So, but seeing that we were that we found that the information that doctor give to the patients are clearly, so it's not changed for every round that we do the survey. So and also that the doctor are welcoming and also the friendly to the patients. And is here, and also that quite good, is very high for the respect of the patients, and also that the privacy when they come to visit the doctor, and also they explain they did the experience discrimination from the healthcare provider, and also no, it's just only that 5% they still have. Next, please. And they also that have the how to say that they have decision to make the treatments, and also that provide time enough for the patients. So for patient clinical questions, as the same, the number of the response for the first round. So in with the 11 ART site. Please. And most of the PLHV, they know that what they're on ART regimens or ART treatments. And so for regimens, is still some that I know do not know the regimen is about 8%, and second 24% that they still don't know the regimen what they're taking. So just okay. Is near the knowing what is the viral load testing. I think that right now we face out that before that we send the viral load testing to the Malaysia center to do the test, but now in these 2 months, so we use the gene expert to test the viral load testing, and I think is also that during the it is not quite smooth for these, and some that they cannot come to do the viral load testing. But okay. But if we look and this they know the last viral load testing is just only 58% is half, but we still, as I say, that they might face on the problem with the COVID-19, and also that we do during the transition of the viral load testing. So, but they still know that the viral load suppressed. So most of the patients who were viral load test, they got the result, and they know that the result. And here is also that just only half is not only half that know that the neck viral load testing, as I mentioned, that for transition of the viral load testing, so some ART site cannot inform the patients so what time exactly to come to test the viral load because of the system of the test the viral load is not stable. It's here that we add the additional question for the of the patient who come to visit the doctor. Do they get the vaccination or not? So just only 10% that they get the injection vaccination. So and the first dose and second dose is just only the 6%. The most more 80% is no vaccinations. The reason that why they're not vaccination is their fear of the getting vaccine. So, but the second is 13% is completely is there no condition or not giving by healthcare worker because they are have the OI they have opportunistic infection or severe ill, so stay at the hospital. And some of okay, there's could you skip it? Is here the question that we so is here that question that we expect to add in the next round. So okay, can you skip it? Is here the result from the IPBS that we do the S&D we add into the IPBS survey. So is there any in your family who has show stigma to you? So for female sex worker is about 46%, and MSM is higher than female sex worker, 80. And then they got the stigma and discrimination is more than female sex worker. So in here, if we compare, so in the past 12 months, have you ever been denied on school enrollment or the employment? So the sex worker is higher than MSM. And the third question is, have you ever been denied healthcare worker service by doctor or nurse? So if we compare that with the female sex worker, that the MSM is higher than. So if there are sick, so they go to the hospital, they receive was a healthcare worker serviced by doctors or nurse also, and also that MSM is higher. So I can see that most some female sex worker or some MSM. Okay, next please. So our strategy and policy is the integrated S&D into the existing HIV quality improvement program. So revise health literacy to include S&D and key population, including S&D experience in IBBS survey for female sex worker and MSM. Strengthen that CSO engagement and the linkage of the community S&D reduction in initiative that in CBM. So we continue that quality improvement monitoring for S&D and enhancing the PDSA method. So conducting S&D in next surveys, searching for the budget support. Please. So for quality improvement, S&D implementation and intervention that we S&D data just shared to the result to ART site after. So we finished is we still that cannot share now. So we will share that the result back to the ART side, and also that we plan to do the training workshop in virtual training because of the restriction of the travels. So, and S&D feedback mechanism with engagement of the community has been developed through the community-based monitoring tool supported by SKPA projects. But the data collection was the pause during the COVID-19 that outbreak in Laos. So we also that we continue to develop the S&D toolkit and training package for healthcare worker and also the PLHV with CDC, TUC Thailand coordinate, and also that with the CSO. And we continue to S&D and questions. Monitoring and enhancing. So, okay. Next slide, please. And in near futures, S&D activity would be expanded to new ART site service, as we call that point of care. So right now we have the seven point of care. So we also that transfer the stable patients to the point of care, and we conduct the S&D activity in there also. So the question about the HIV stigma and HIV index of engagement that were created during last workshop, and we agreed to start data collection in the next round of this. Okay. Is near that the question about the HIV stigma that we will add into the next round. So we have I have 5 questions. So most that we focus on the most people living with HIV has many sexual partner, or they get the infection with the HIV because they're engaged in responsible behavior, or most or do not care if they're infected other people, and also that should feel share of shame of themselves, and also that the last question is HIV punishment for the bad behaviors. Next, please. And as here that the HIV index of engagement that we will put in the next round. So I will not in details. Please next. So for the next step, that for the performance measurement, that we will continue HIV related to SND monitoring quarterly basis. So for the quality improvement according to the SND activity, that we will continue to monitoring and disseminate SND routine monitoring result in the hospital. So it means that the ART side, they will do it. So adding the set of the question about the HIV stigma among the healthcare worker, we start in the next round. That we will continue the SND reduction activity as part of ongoing quality improvement efforts in on ART side, refresh TOT on training on the SND reduction activity. So it is that in the process, we got the budget from the Hansa project and also that the PEPFAR. So we hope that next year we can conduct it. So, and then we will develop up the change package to promote the sharing of the successful strategic win-win on the site. For the patient feedback, we still continue it. Could you please go back? Okay. And we also have been adding a set of the question about the HIV index for of engagement. So for the QI coaching aside, we will select some hospital for on-site coaching, but I think is this time will be the virtual coachings. So mentoring of the hospital-based QI focus person by chest. So we also that leg of the, so we just only have the full staff for monitoring or coaching on site for the on 11 ART sites. So I think the refresh of the QI coaching group to share the experience also will continue, and we will organize the lesson learned on the quality improvement in this month, in the end of this month. So, and also that for PDSAs, we also that we will refresh. So that's all for my presentation. Thank you.
Thank you so much, and for a fantastic presentation. And my apologies for a faltering start. It appears that not only myself but also my computer has struggles this early European morning because it crashed. So apologies for that. But fantastic presentation. Great to see the elements of COVID and key populations coming in as well. That is also something new. It's absolutely amazing to see that. Congratulations for that presentation. I would like to invite participants, if they would like to raise a question, to either raise their hand or write in the chat. And we actually already received quite a few questions in the chat. So I will read this out first. Please, if you also have a question, do feel free to raise your hand. Okay.
Easy. I got the question is, how long does it take to process the complaint from the patients? So now we take for 1 month.
So it takes about 1 month, because I understand this has to do maybe with the survey has aggregated data and
yes.
So how do you go then to these individual issues of complaints that are coming up in the service? How do you address them? And so it's 1 month, but how do you address them? Because you have this comment boxes, as we know from previous presentations, in terms of consumer feedback. But then how do you address them in the service? Could you maybe also elaborate a bit on that one, please?
So we also that have the book, and also that we have the small questions that are done by the peer educator, that is mean the PLHV, that helping the doctor in the ART side to ask the patients.
So individual complaints come up there and are then being processed within a month.
Yes.
Okay, thank you so much. There was also a question from the Cambodian CDC, the Sodara Chan, who asked about treatment regimen referred to first line, second line, third line, or specific regimen people living with HIV actually on. Could you also answer
right
that
now
question,
we
please?
just on yes, right now we just have only two regimen, is first line and second line. So for first line that we use the TLD. So we have that we on the transition from the other regimen to the TLD, that with the dolutegravir. Right now that we are most of the about 87% of the patient is got the TLD.
Okay. Thank you for that. There's two more questions that I see in the chat. Once again, if people would like to raise a question, feel free to raise your hand or write it in the chat. There's a question from Dr. Anita Sulaiman in Malaysia. She asked, despite men who have sex with men receiving bad services, 21% compared to female sex worker, this did not prevent them from going to hospital. I suppose and then there is the MSM, understanding on the rights for health is so strong. Do you have any explanation for that? So why, despite receiving those bad services, they still manage to go to the hospital?
How to say that? I think that if we compare to the female sex worker, that it might be that the cultures also that in Lao that we, so but we try to do the service, special service for MSM, and we realize that the result is coming like this, so that we been improve the service, and also that right now that we have the special service for MSM, and have the fast track service for them right now. And also that, so hope that for the next round, the is discrimination is been reduced.
All right, thank you.
I answered your questions.
Well, it's not my question. So if Dr. Sulaiman wants to come in, please feel free to specify your question.
Dr. Anita?
Anita, see. Dr. Anita?
Okay, all right. Thanks, Kamala. Yeah, I just feel fascinated that despite they get the highest proportion having bad services, that does not prevent them from coming back to the hospital and get treatment. So I suppose that the need for healthcare or the self-stigma is not as high. You get what I mean? Or not? If the self-stigma is high, that itself would prohibit them from going back to the hospital for care. So this is something that I really like to learn Lao, how do you tackle the self-stigma? This is my hypothesis that probably the self-stigma is not that high. That's the reason why they keep on going back despite having given bad services. But anyway, I think learn a lot from your presentation, Dr. Kamala. Thank you.
Thank you, Dr. Anita. So we have actually a last question from Margaret Jasmine from UCSF, and she asks, did you find a higher level of fear and refusal of COVID-19 vaccine among people living with HIV, or is it about the same in the overall population?
I have to say that if we compare to the general populations, so that there also the fear of the vaccine. So right now that we encourage that the age of the 18 and to upward to come to get the vaccination, but right now we got that just only that 30% of the population that get the vaccinations. So yeah, by providing the vaccine, they also that have the adverse of the or side effect from the vaccine, so there are fear from that.
Okay, thank you for that. There is a last comment, or there's another comment that just came in, and that is from AFAO, if I have it right. Saiti is asking, would be great to learn more details how CHAS and CBOs, NGOs work on stigma and discrimination activities in Laos. If you can shortly answer that question, that would be appreciated. Thank you.
Can you repeat the question again?
Yes, I'm looking it up just now because I have to swap in between screens. So the question is, would be great to learn more details on how CHAS and CBOs, NGOs work on stigma and discrimination activities in Laos. So if you can elaborate a bit more on the cooperation between CHAS and the CBOs, NGOs on S&D work in Laos. But if you can keep that to a 2 minutes intervention, please. Thank you.
Okay, for S&D that we have that closely to work or collaboration with the NGO such as the QIS and also the PEPFAR that to do the S&D in the community. So, and the activity is I think that is ongoing. So they also that we do the survey and on develop the curriculum for the reducing the stigma in the community. So
all right. Thank you for that. I suggest if colleagues have other further questions that you directly contact Dr. Kitmala, but I would like to thank you very much for this very enriching presentation. With that, I would like to close the part on Lao, and I would like to go immediately to the presentation of the Malaysia country team. So just in order to avoid the challenges we faced just now, I would like to ask Charlie if he can put up the slides. It's Dr. Riza Turami that is going to present. So over to you.
Okay, thank you very much, Quentin. I'm going to put up the slide myself, if that's okay.
Wonderful, excellent. Thank you so much.
Okay, so thank you very much, Quentin, for the introduction. I hope everyone can see my slide now. I'm turning it into slideshow. Is that full screen?
This is perfect. Thank you so much.
Okay, good. Thank you. Okay, I'm Isa from the MOH Malaysia. So today I'm going to present on the progress update for QIS+D in Malaysia. So this is our timeline for the QIS+D projects, which was just started back in February 2020. So currently we are about 18 months in the project. Okay, and just a brief background, I'm not going into detail on this, but basically in Malaysia, there are 3 parties that are involved in this QIS+D project, which are HIV sector from the MOH, Research Institute, which is IHSR from the MOH, and also Malaysia as Council for the NGO side. Okay. In terms of the COVID-19 implication, just as what we had heard from many other countries, the pandemic has affected pretty much almost everything in the project. Our QIS+D are still ongoing, but however, almost a lot of things has to be changed, has to be converted to virtual. For example, the QI coaching session, training, and then progress audit meetings with the facilities, PA exchange activities, etc. The intervention period was also extended from 6 months to 8 months, and our re-evaluation, which was initially planned in June 2021, was postponed to August 2021. So actually, we just finished the data collection for re-evaluation survey last week. Okay. So basically, this is quite a fresh result that we got from the survey last week. I'm going to share the result now. This is basically our survey tools, in which used during the baseline and also the evaluation survey. And it is easily accessible, where the respondents can fill out the survey in their mobile phones wherever they are. And this is the dashboard on the SND survey database. Basically, this platform itself is actually developed by the Malaysian Council. This dashboard allows each facility who was given access to monitor their performance in real time when the survey was opened during data collection. Okay, so in terms of the data collection for the performance for the indicators, during the baseline survey, we included 11 facilities from 6 states, where in each state we have 1 hospital and 1 clinic. For the re-evaluation survey, however, we only include 10 facilities because one of the hospital in Selangor is actually converted to a full COVID hospital and becomes a center for the COVID-19 for the country. In fact, this hospital Selangor did not manage to even start on the intervention because the hospital was converted to full COVID-19 hospital just after the baseline survey was conducted. Okay, in terms of the total respondents, as you can see here, the total number of respondents for both surveys during the baseline and re-evaluation period, there are about 50% drop in both healthcare worker and PLHIV survey. For the healthcare worker survey, for the clinics are doing quite well in terms of there's not much difference between the number of respondents for the baseline and re-evaluation. However, for the hospital, it's quite, I would say, more than 50%. In fact, in the hospital Penang, is less than 10% than the initial number of respondents during the re-evaluation compared to the baseline. And also for PLHIV, we also see almost a 50% drop in the total number of respondents. Okay. I'll share the results for each of the surveys. So firstly, it's on the healthcare worker surveys. For this one, the first 3 indicators, the first and third indicator on worried taking blood from PLHIV and wearing double glove, we are seeing almost all the facilities has a reduction of percentages, except for few facilities. For the second indicator, however, some facilities, there are more than 1 facility that showed an increase. I would say that the second indicator, which is on the avoiding physical contact with PLHIV, this is most likely true, but then because of the new norm of social distancing, which is exercised during the COVID-19, so it could be not just be towards PLHIV, but it might also apply to all other patients. Okay, for the 4th and 5th indicator on unwilling to care for PLHIV and providing poor care to PLHIV, all facilities showed a decrease except for Hospital Penang. We can see that in the indicator 5, there's a slight increase in Hospital Penang percentage, but just bear in mind that the number of respondents during the re-evaluation survey in Hospital Penang is less than 10% as compared to the baseline. So the result is not comparable for this facility. Okay, and for indicator 6, which is on the infection control guideline on status protocol to reduce risk of healthcare worker becoming infected with HIV. As you can see here, the percentage is increased in almost all of the facilities. This one we have to, we don't have a specific guideline on this, but it is clearly spelled in the National Standard Precaution Guideline for Infection Control. So it is not specific, it is not a specific guideline for on HIV only, but then it is included in the standard precaution guideline. Okay, and indicator 7, no written guidelines to protect HIV from discrimination. Yes, we don't have specific guideline for SND towards HIV, but this is clearly spelled out in the Code of Ethics and Medical Code of Conduct. For some of the facility like Johor, in facilities in Johor, they do come out with their own guideline to be used at the facility level in reducing the stigma and discrimination to in protecting HIV from discrimination. And then for indicator 8 on the woman living with HIV, should not be allowed to get pregnant. As we can see here, almost all facilities are showing decreasing percentage, except for Clinic KL, which is the same 34%. This is actually consistent and in line with the fact that we just launched the new recently released the new PMTCT guideline of HIV and syphilis guideline, which was published in June 2021, in this newly released guideline, it gives an extra emphasis on human rights issues related to sexual reproductive health for women. So as you can see here, the percentage in almost all of the facilities are decreased during the re-evaluation survey. Okay, we also include some of the questions on the healthcare worker attitudes towards key population. Here, there are 4 key populations that was included in the questions: the PWID, MSM, female sex worker, and also transgender. In almost all facilities, the indicators or the percentage is decreasing, except for the TG group. The result is only available for August 2021 because actually this question was result during the August 2020. So we only have this result in August this year as a baseline for the TG group. Okay, now we are moving for the PLHIV survey indicators. For indicator 1 until indicator 4, as we can see here, for the first 4 indicators, it is quite difficult to make a general conclusion on the result for the PLHIV surveys, but we do see some declines in some of the indicators, and we also found some increments in some of the indicators. For example, clinic not welcoming and not friendly, not treated with respect, and no PNC during my visit. This situation where the problem seems to be increased in some of the facilities might be true, but it is not only affecting the PLHIV services, the PLHIV patients, but it might also happening to all other services in the facility because the situation of the chaos that the COVID-19 is causing us. So everyone is, in terms of the facility, is quite congested. There are very much limited time for in catering patient, etc. Okay. And for indicator 5 on experience discrimination from healthcare workers, as we can see here that all facilities actually showed a decline. Whereas for the indicator 6, 7A and 7B, again, these indicators are related with the on the decision making regarding illness, adequate time spent by doctor during visit, inadequate time spent by paramedic during visit. This again might be true for all healthcare services due to the chaos that COVID-19 has put us in, not just limited to the PLHIV only. Okay, we also have I'm just going to share on some of the results for treatment literacy questions in our survey. As we can see here, these 2 indicators on ART showed in increment actually in the hospital sites. For the PLHIV, not on ART, and also PLHIV didn't know the ART regime. So as you can see here, the last 3 sites, Hospital Penang, Johor, and Pahang, we can see that actually there's an increase in the percentage. I would say we can say that this is because one of the collateral damage caused by the pandemic itself, where the initiation of the ART itself was delayed in the undiagnosed patients. So especially in hospitals where the workload of the COVID is a lot on the hospitals. So appointments for patients, not just PLHIV, are given at a much longer interval. The appointments was spaced out much longer than usual. So as you can see here, actually maybe one of the things that's happening during the COVID is the delay in the initiation of the IRT itself. Okay, and then the next one is on the PLHIV didn't know the most recent viral load test and also whether the PLHIV is virus suppressed or not. This is also negatively affected during the re-evaluation. Some facilities showed an increase in the percentages of PLHIV who didn't know the recent viral load test and decrement in the percentage of PLHIV who are virally suppressed. So again, we can see that as a whole, the treatment literacy is quite negatively affected during the based on the re-evaluation, the survey result. Okay, that's for the performance measurement that we see, the result that we see in the re-evaluation. I'm going to share on the QI intervention, monitoring, and also coaching. Just as a brief overview, I'm not going to go into details of the different interventions. Basically, there are three, we particularly look at three aspects, which are the structure, process, and people, where people includes both healthcare worker and PLHIV. So example of structure-related interventions are like community establishment, one-stop center, in clinic and non-discriminatory queuing systems. For example, of process intervention include reinforcement of infection control practices, regular audit and monitoring of client satisfaction. For people which include both the healthcare worker and PLHIV, we conducted interventions such as trainings, raising awareness, and also community engagement. I just want to highlight here one of the mechanisms that is in place to gather feedback from KP, but specifically, this is an incident reporting system established by the Malaysian AIDS Council for KP to report any incident to be investigated by the council. Currently, this system is still manual and paper-based, but an online platform is currently being developed, and the MSC is planning to launch it by December this year. Okay, and we also have a public complaint management system. This has been in place for quite some time. It is being managed by the government, where any complaint to government agencies can be submitted by anyone, not just limited to the PLHIV only. Okay, in terms of QI intervention monitoring for this project, basically we develop a simple template or simple, I would say, this is actually a Google Sheet, where we include 10 items to be recorded regarding the QI intervention. So we include facility names, sample and respondents of the survey, name of the intervention or strategy, which factor is being addressed by intervention. This is particularly important to see which factor is being addressed, and all other details of the intervention, such as when it was started, where it was conducted, who are involved, and the status. Some of the intervention actually is still ongoing. So we also ask for any target of completion if the intervention is not completed yet. Okay, for QI coaching, so this is what we did for QI coaching, where initially, yes, at the initially during the design meeting, we do plan like a physical or in-person session with the different facilities, but because of the pandemic, we converted everything to virtual. So we had a virtual progress update, and we also held a monthly webinar to talk on the technicalities of performing QI study. Okay, and then that's for QI coaching. And I'm going to share on the one, I would say this is the one that we are going to highlight, intervention that we're going to highlight in this presentation, which is from one of the facilities, which is the clinic in Selangor. Okay, so one thing that I would say the points that we need to highlight for the clinic Selangor is on the success factors that is present in this facility, which is there's a solid commitment from the top level managers. There's a strong collaboration and participation by the NGOs, the Insaf Muni and also Malaysian AIDS Council, and also the continuous commitment and involvement of the healthcare worker at the facility itself. Okay, this slide actually summarizes the indicators for Clinic Selangor for the healthcare worker survey and also PLHIV, where we see almost all the indicators are showing reduced in percentage, except for indicator 7. This is on the standard precaution, which is actually on the standard precaution for infection risk for healthcare worker, which is understandable because we don't have a specific guideline for PLHIV per se. Okay. This is a problem analysis chart for Clinic Selangor because this is what the facility came out during the early of the project. I just want to highlight here some of the ones in red, the bubble in red, on the personal bias, cultural bias, religious bias, being judgmental, and also poor staff attitude. So these factors are quite, I would say, quite complicated to be addressed. But this is one of the things that is being done in this facility, where one of intervention was done to address this factor, which is the intervention that I'm going to share in this presentation is on Kasih project. Kasih basically means Kasih is a Malay word which means caring, love, or compassion. Okay, so this project was actually initially started back in 2018, where it involved the methadone clients, but starting from 2020, it was expanded to include PLHIV patients, and was started back in 2020 towards the end of the year. Okay, the objective of the Kasih project, of course, as we can see here, in the end, it aims to reduce the stigma and discrimination among clients, staff, and community. And this project actually aims to create a collaboration and cooperation between the government agencies, CBOs, and also communities. Okay. This is I'm not going to talk into detail on the what's happening or implementation strategy in detail or the work process, because I'm going to share a video that explains what Kasih project is all about. Okay, I hope everyone will be able to hear the sound. Okay, so I think you get the I would say what the Kasih project is about based on this video. It's quite simple in the sense that it doesn't involve like extraordinary or complicated things, but then it is something that actually caters or address the most I would say crucial thing, which is in terms of the communication interactions of PLHIV with the community, with the staff. So all those things was in place or was included in the intervention. And as we can see here, of course, there are challenges in finding and training the volunteers, patient safety issues, the COVID-19 cases which are increasing. but the facility itself takes a lot of things and do a lot of things to find a solution, including collaboration with the Insaf Muni, the NGO, Malaysian Arts Council, regular training for the clients who volunteers to be involved in this project. And also in terms of safety precaution, the vaccination was expedited, including clients' family in the clinic itself. And also the volunteers were trained to wear PPE. So this, I would say, the simple things that address the communication, the interaction, the engagement of PLHIV with the community and also staff. It improved the networking between the clients, CBO, clinic staff, and dental staff in a great way. And the feedback that was received from clients is that it does reduce the stigma and discrimination that was experienced by them. And of course, it empowers the clients where they're able to monitor and assist other clients who are on duty. Okay, that's on QI intervention, the different intervention that was made throughout the project. I'm just going to share a little bit on the MySAS, which is Malaysia Stigma Evaluation Survey, which was conducted this year. It just launched in January, and the data collection process was conducted from January until February 2021. One thing that I need to highlight here is that this is an online survey as in comparison to the stigma index, which was conducted face-to-face. There are 7 sections in this online questionnaire, from the background of respondent, includes disclosure, personal experiences, internal stigma, experiences with the healthcare services, human rights, and also experiences on SND due to appearances or behavior. Okay, this is a preliminary result from the survey. We received, the MySAS 2021 received about 1,107 respondents. Majority of them are MSM, it's about 60%, and it also include about 28% of non-KP respondents, because the survey is open to all PLHIV, not just limited to KP. It is important to highlight here that only 28% of the respondents are involved in social network or support group for PLHIV. And results, some preliminary results related to the stigma and discrimination that was extracted from this survey. 90% of the respondents satisfied with the services provided. 47% of the respondents were advised not to have sex, and about 2% of the respondents claimed they were denied treatment when they encountered health services. For non-HIV care and treatment experiences after disclosing their HIV status, about 3% denied treatment or services, and about 4% verbally abused. About 23% experienced that the healthcare worker avoid physical contact or wearing double gloves during the treatment, during the care and treatment. In terms of the treatment literacy, 95% of the respondents are already on ART. However, only 58% has undetectable viral load, and 13% did not do viral test or do not know what is viral load. Okay, I'm going to the last section of the presentation, which is on the next steps. Yes, of course, it's been challenging, and yes, we face a lot of challenges during this first 18 months of the project. Of course, because of the pandemic COVID-19, where actually when we first started the project, it's just before the COVID becomes a pandemic. So I would say that throughout the project itself, we are doing the project side by side with what happened in the COVID-19 pandemic. Another challenge that we just have to bear in mind is on the effectiveness of the intervention, or I would say effectiveness of awareness or training program, especially when it just has to be converted into virtual platform. And also the low response rate during re-evaluation data collection, the patient follow-up interval extended, mobilization of the healthcare worker to COVID-19 vaccination centers and other hospitals is, of course, is a challenge that we have to face during the data collection. Even some of the facility do have to suspend the continuation, or do have to suspend the activities of this QIS+D project because of the focus that was shifted towards COVID, handling COVID-19 in the hospital especially. In terms of the next step, next intervention they are planning is a national level intervention based on re-evaluation results. So looking at the re-evaluation result, knowledge is one thing that we do need to work on. So the national team is planning to make an update on HIV. Basically, the content is on infection control knowledge among healthcare workers, the reinforcement on codes of ethics and medical codes of conduct, especially on patients' rights to reduce discrimination, awareness about U equals to U, treatment literacy, and also sexual reproductive health rights for women living with HIV. The targeted audience are all healthcare workers, including dental. I just need to highlight dental here because sometimes it's just being left out from the picture, but actually they do have a lot of encounters with fatal HIV. So targeted audience here are all healthcare workers, including dental side. And for now, the approach is a short webinar sessions. This is not ideal, but then we are working with what we have or what we're facing at the moment. So rather than not having it at all, at least we have a short webinar sessions to do to disseminate the updates on this matter. Okay, and also we are, this one is in the pipeline. We plan to compile all the QI intervention into a compendium of intervention for reducing stigma and discrimination at healthcare settings. We just done with the first draft. Currently still working on improvising the draft. Once the compendium is complete, we are going to distribute it to all healthcare facilities as a reference to reduce SND in the health facilities. Okay, and the project itself, we're planning to the scale up. This is scale up planning, where currently we are in September 2021. We just done with the first cycle of intervention for the phase 1 facilities. We initially planned of a scale up this year, but then of course, the situation of the pandemic is just make it less possible. So we plan to do a scale up in June 2022, which is next year, where one facility from each of the 14 states will be selected, will be recruited into the project, and we will repeat the cycle that we do for the phase 1 facilities. And hopefully for the phase 2 facilities, the intervention activities can start it in August next year until February 2023. Okay, so I think that's my second last slide. Yes, and thank you for any question and answer. I will also invite Anita from the MOH if anyone has any questions. Thank you.
Thank you so much for this comprehensive presentation, Dr. Iza. There's a few questions in the chat. Mindful of the time, I'll hand it over first to Harry, and then I will go to the questions in the chat. Harry, over to you.
Okay, thank you, Dr. Azizer. I think the presentation was again it's very impressive. I have two questions basically. One is related to the CISPA. As you mentioned that any incidents can be reported through this feedback system. So does this incident can only report it something related to the healthcare settings or other settings as well? And another two things, the second one is about the MySAS 2021. I just wondering if you have a knowledge about the recruitment process of the respondents, because I think the recruitment of the process of respondent from the survey is also resulted the quality of the overall result of the survey itself. So can you explain a bit more on that? Thank you.
Maybe I can help Iza responding to those questions. Let me respond to the second one first. MySAS. Now, MySAS is actually, I would say, the work coming up with questions actually by the community under the stewardship of Malaysian AIDS Council. So the questions are all being reviewed by the PPL-HIV representative from every partner organizations under Malaysian AIDS Council. And the recruitment is also through the caseworkers, through people living with HIV network, within their network. So I would say that the MySAS is entirely by the people living with HIV, which is guided by the academia, which is the University of Science of Malaysia, to ensure the methodology is technically or scientifically sound, because as you know that MySES is a national template. Whatever results coming out from this template that would be elevated to higher level, the policy decision maker need to be scientifically approved. So therefore, not to worry, the recruitment, the coming out the questionnaire, the review is all done by the people living with HIV representative under Malaysian AIDS Council. The first question is about CISPA. CISPA is actually the government platform for whatever complaints, not limiting to health. So normally CISPA will receive any complaints if it is related to health, whether it is health regarding health facilities or whether it is regarding treatment or anything about health, will be channeled to Ministry of Health. So in Ministry of Health, we have a unit that look into every complaint related to health matters. So if it is related to HIV, it will be channeled to my sector, and we will given maximum 14 days to respond to those complaints. All right, Harry, did that answer you?
Yes, thank you, Dr. Anita. Thank you so much for this information.
Right.
Again, bravo, Malaysia.
Thank you, Dr. Anita and Harry, for asking that question. There's also a question from Angelo, and he's asking how long was the time period between your baseline and follow-up surveys, and did any major COVID-19 lockdown happened during the intervention period? So he has a question about that. Maybe Dr. Isa wants to respond to that.
Yep, the baseline was collected back in August 2021, and the re-evaluation was the baseline was August 2020, and the re-evaluation was August 2021. So it's about 1 year difference. Actually, the major regarding the COVID pandemic throughout the 1 year, actually we had our third wave of COVID, where we see thousands of cases, daily cases, starting in actions taken about September, October 2020. So in terms of the lockdown, yes, we had our third movement control order in January 2021. So yes, we do experience a major lockdown throughout the period.
Okay, thank you for answering that question, Dr. Isa. I see there are no more questions. Your presentation was also very comprehensive, and thank you for that. Mindful of the time, I would like to invite the participants to take a break. We have a 15 minutes break foreseen, so I would suggest that we reconvene 20 minutes before the
we're going to Charlie's going to give some instructions. We're going to take a screenshot before we break. Sorry.
Okay, good. Go ahead, Bruce.
Yeah, Charlie.
Yes.
Yeah, so go ahead.
Sure. So if everyone can please turn on their video so we could take a group photo. Just hold a smile for 30 seconds.
Oh, we got more popping up. That's great. Okay.
Okay, great. Thank you.
Okay.
So we will take a short break. Let me just bring up the agenda really quick so folks can see what we have for the second half of the meeting. So we're pretty much on schedule. So let's take a 10-minute break and come back at 9:40. And then we'll have our presentation from Alex. And I think that's it.
Okay.
So everyone please take a break, and we'll be back in at 9:40. All right, welcome back everyone. I hope you all enjoyed your break. We are now joined by our guest speaker, Alex Carulian. So I ask that you please turn on your videos once more for another group photo so that we can include him. So if everyone could please turn on their videos once again. There we go. Just gonna wait for a few more so we can get this first panel at least lit up with some videos.
There we go. There's just need a few more.
Okay, I got some, so thank you very much. And I will now pass it over to Bruce, who will introduce our guest speaker.
Great, thanks, Charlie. So it's my pleasure to introduce my colleague and collaborator, Dr. Alex Karoglian, who is the director of the Division of Education and Training at the Fenway Institute and the founding director of the Massachusetts General Hospital Psychiatry Gender Identity Program, and is also an associate professor of psychiatry at Harvard Medical School. Alex leads innovative and culturally tailored training and technical assistance programs for over 1,500 combined health centers and HIV organizations and health centers across the United States. At Fenway Health, he works as an HIV psychiatrist, caring via telehealth for LGBTQIA plus youth, people with substance use disorders, and people with incarceration experience. He has published over 60 peer-reviewed articles, reviews, and textbook chapters, including many on intervention strategies for HIV, LGBTQ plus youth, substance use disorders, and technology in healthcare. And he also directs 2 senior clerkships on caring for patients with diverse sexual orientations, gender identities, and sex developments. And I'm really delighted that he's able to join us at this late hour of the evening in Boston and talk to us about mental health and the intersection of stigma for people with HIV in key populations. Thanks a lot, Alex.
Thank you so much, Bruce and Charlie. Hi, everybody. It's great to be with you today. And I have my coffee here to make sure I'm as awake as possible for this event that I've been looking forward to. I'm coming to you from the 8th floor at Massachusetts General Hospital in Boston, and I know that it's morning where you all are, so I very much appreciate the opportunity to connect with you. And Bruce had asked me to speak with you all today and hopefully facilitate a discussion around mental health for mental health care specifically for LGBTQI plus people. So I'm going to share my slides, and I look forward to some discussion hopefully afterwards as well. I'm going to start by presenting a framework that I find very helpful to understand the relationship between stigma and adverse health outcomes in a variety of populations. This is based on what's referred to as a minority stress framework that was originally developed by Elon Meyer and was formulated for sexual minority people. And that was referred to as a sexual minority stress framework. Later, this became something that was adapted and referred to as a gender minority stress framework for transgender and gender diverse people. That being said, it's a very helpful framework to understand the relationship between stigmatized, minoritized populations and adverse health outcomes in general, including for people living with HIV who, of course, as we know, and as is the central focus of this learning collaborative, experience disproportionate stigma. The idea here is that stigmatized populations, minoritized populations experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately, at a much higher prevalence than the general population. And we think of all of this as external stigma-related stress. This stigma-related stress can take a toll for many people over time, lead to, for example, disruptions in certain general psychological processes like coping skills, emotional regulation, interpersonal functioning and relationships, having certain beliefs or what we call in mental health cognitive structures that may be protective in the moment, but over time can perpetuate distress. And all this external stigma-related stress can also lead to internal stigma-related stress. For example, internalized HIV stigma, internalized homophobia, internalized transphobia, expecting rejection based on your identity because you're so accustomed to it, or identity concealment to prevent mistreatment and abuse. And that's also related to HIV status and disclosure. And all this external stigma-related stress, we think, is related to what we see in the research and the literature, which I'll describe to some extent in a moment, which is a much higher prevalence of mental health problems among people living with HIV and among LGBTQ people as well. Higher prevalence of depressive disorders, anxiety disorders, post-traumatic stress disorder, in some cases substance use disorders, thought to be a way to cope with all this stigma-related stress. And this arrow between stigma-related stress and mental health problems is bidirectional, as you can see. So while it's the case that external stigma-related stress in response to a person's HIV status or LGBTQ identity can lead, based on this framework, to mental health problems, it's also true that having mental health problems is inherently stigmatized in most of the world, in most communities and cultures and countries around the world, including here in the United States. And therefore, having mental health problems as a result of mental health stigma can increase stigma-related stress. So this is somewhat of a feedback loop, and one can worsen the other. And it's important to understand this is bidirectional. Stigma related to HIV, to being LGBTQ, can lead to more mental health problems. And having mental health problems in and of itself can create more stigma that one experiences in society. And all of this is associated with decreased self-care, decreased engagement in healthcare, including HIV primary care, including mental health services, and down the road, a higher prevalence of various physical health problems as well, including a higher prevalence of adverse HIV-related health outcomes, including lack of virologic suppression. Now, there are some studies I'm briefly going to touch upon, all of which selected here are specifically from the Asian continent. And these are studies that showed this association between HIV stigma in general, and adverse mental health. This is a study of stigma, depression, and quality of life for people living with HIV in southern India. It's a community-based cross-sectional study of 400 people living with HIV. 27% of these folks experienced severe forms of stigma that included personalized stigma, negative self-image, perceived public attitude, and disclosure-related concerns. And people living with HIV with severe personalized stigma and negative self-image had 3 times higher risk of severe depression than people who did not have severe personalized stigma and negative self-image, and 3 times higher for people who had severe personalized stigma compared to people who didn't, and 2 times higher risk of severe depression for people who had negative self-stigma compared to people who did not have negative self-stigma. So there's this relationship between severe personalized stigma and higher risk of severe depression, and negative self-image and higher risk of severe depression. People living with HIV who had severe depression had almost 3 times higher likelihood of significantly poorer quality of life than people who did not have severe depression. Another study from Thailand looked at stigma, depression, and social support among people living with HIV. They interviewed over 400 people living with HIV in northern and northeastern Thailand and found depression was significantly associated with both shame and perceived stigma. Self-reported emotional social support was negatively associated with depression, so people with more emotional social support were less likely to have depression. Having internalized shame and emotional social support were significant predictors of depression after controlling for gender, age, income, and education, interestingly. And HIV-related stigma had a negative impact on psychological well-being of these people living with HIV, and emotional social support remained a protective factor against depression. In the second bullet, it should actually say lower emotional social support was a significant predictor of depression. A study of HIV-related stigma and mental disorders in Cambodia engaged over 1,000 adults living with HIV in 6 provinces. They administered the People Living with HIV Stigma Index and a short version of the General Health Questionnaire. After controlling for a number of possible confounders, they found that higher levels of mental disorders were significantly associated with higher levels of experiences of stigma and discrimination in families and communities, higher levels of internal stigma, and higher levels of fear of stigma and discrimination in family and communities. So high levels of mental disorders were associated with these various forms of stigma. Another study of HIV-related stigma and depression among men who have sex with men in Beijing in China was a cross-sectional survey of 266 men who have sex with men living with HIV. And they found that higher HIV stigma scores were associated with higher likelihood of depression and negative coping skills. And these higher HIV stigma scores were negatively associated with HIV status disclosure and with availability of social support networks. So this is connected to that model that I showed earlier with regard to stigma, minority stress, and things like identity concealment and lower disclosure of stigmatized identities. Another study here looking at stigma and depression among young people with perinatal HIV in both Cambodia and Thailand engaged 195 adolescents and young adults with perinatal HIV. And they looked at HIV-related enacted stigma with specific questions in structured clinical interviews. And they looked at depression measured with the Child Depression Inventory for children if the participants were younger than 15 years old, or the Center for Epidemiologic Studies depression scales for youth who are older than 15. They found that frequency of depressive symptoms was almost twice as high among adolescents and young adults with perinatal HIV who did have HIV-related enacted stigma compared to those who did not have HIV-related enacted stigma. And finally, this is a study of HIV and drug use-related stigma and mental health in Vietnam. So they engaged 241 people living with HIV who inject drugs. This was using baseline data from a randomized controlled trial. And they found that both perceived and internalized drug-related stigma measures were significantly higher than HIV-related stigma. And HIV-related stigma was negatively associated with mental health status. So the more HIV-related stigma people had, the worse their mental health status was. Interestingly, they didn't find a relationship between drug-related stigma and mental health, but they did find a relationship between HIV-related stigma and worse mental health. So those are just some studies to show in the Asian continent that a number of people have looked at and demonstrated this association between HIV stigma and worse mental health in one form or another. Again, these are associations, they're not causative relationships, but the reality is, as we discussed earlier, that this can very much be bidirectional, with HIV-related stigma contributing to worse mental health and mental health itself being stigmatized. These are some helpful statistics and figures from the Ryan White HIV/AIDS program in the United States, which is the equivalent of our Ministry of Health HIV program here in the US that you may have already spoken about in the collaborative. Studies have shown strong correlations between HIV and mood disorders, including specifically and primarily anxiety and depression. So they're showing here patients who were retained in HIV primary care who had a positive mental health screening and were referred for diagnosis and treatment. 75% were found to have depression, 70% were found to have anxiety, and 80% were found to have post-traumatic stress disorder. Additionally, 1 in 5 who screened positive were not already in mental health treatment of some kind. We know from a variety of studies that depression and anxiety can lead to non-adherence to antiretroviral medication and not being engaged in routine medical care, increased risk for substance use disorders, inconsistent condom use, and other high-risk behaviors. So what can we do about this within HIV care? We can provide at least annual screening using a validated screening tool for all people living with HIV. In fact, we recommend doing this much more often than once a year. If someone has a positive screen for a particular mental health risk, then we can link them to a mental health professional for diagnosis and treatment and provide a treatment plan with support for following through on this treatment plan and monitor their engagement in this and also track improvement in symptoms with another with a validated screening tool, perhaps the same one that was used initially for screening or a different one depending on what mental health diagnosis it turns out that they have. We focus on screening for depression, which is often found to be the most common mental health problem for people living with HIV. We know that people who are depressed are less likely to follow through on healthcare advice and take their medications as advised. So HIV care practices can make a plan to implement more screening within their practice. This involves educating staff to develop support for implementing mental health screening. And we really want to address the impact of HIV and mental health problems in the ways in which these create stigma and challenges related to stigma for clients. So we want to discuss with staff and the agency how to confront these barriers and really engage the folks in the practice or in the organization in thinking about how to address this. We can decide how depression screening best fits in within the current scope of services. It's not going to be the exact same implementation approach for every organization or for every community. So we really want to think in a more tailored way about how this is going to fit in within client flow within an HIV care practice. And we really want to think about how we're going to respond to a positive depression screening result for a given client and think about what we then do, right? So identifying depression-related resources within the realm of what's possible and how to put these into place for any clients who may screen positive. So we want to initiate screening by adding depression screening into a routine client flow, training staff in the use of screening tools and how these will fit in a sustainable way, and considering initiating a quality improvement project to guide the practice through this process. There's the patient health questionnaire 2-item version shown here. And this asks over the past 2 weeks if the client's been bothered by any of the following. It asks about little interest or pleasure in doing things, feeling down, depressed, or hopeless. So these are 2 main symptom categories for major depressive disorder, as we call it. And if the client screens 3 or higher, then the recommendation is to administer the PHQ-9, which is the more extensive 9-item version. And this really gets at all the major symptom domains of major depressive disorder. Over the past 2 weeks, little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling or staying asleep, sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, trouble concentrating, moving or speaking so slowly that other people could have noticed, or being so fidgety or restless that you move around a lot more than usual, and thoughts that you'd be better off dead or hurting yourself in some way. And depending on the score, we can say that the patient is likely to have anywhere from no depression or minimal depression to severe depression. So it's pretty straightforward as it happens. It can be self-administered, so the client can do it themselves, or it can be administered by a staff member. For example, if there's a literacy barrier, that's okay. You can have a staff member administer it, and it doesn't have to be a staff member who's a licensed mental health clinician. It is said to take 3 minutes to complete. I think that's pretty generous. It's typically much quicker even than 3 minutes. And ideally, this could be completed at each visit when someone is engaged in mental health services to track improvement in depression symptoms. Now, this is a screener for depression. There are also screeners for anxiety, for post-traumatic stress disorder, for substance use disorders. We don't have time to get into all of those today, but I wanted to highlight this PHQ, which is one that's increasingly more commonly used around the world. And if someone does screen as being at risk for a major depressive episode, we want to make sure we have set up depression resources in some way. So identifying either internal resources or external referral relationships that are viable. And that's often a decision-making process or based on what's feasible in terms of having these services incorporated within your facility or developing good external partnerships to refer out for. Here are some resources through the Ryan-White HIV/AIDS program here at HRSA in the US that are free, online, and very helpful. So I encourage you all to check these out, as well as resources from our AIDS education and training centers related to mental health and from the US Substance Abuse and Mental Health Services Administration that has a lot of resources related to integrated care for mental health and trauma-related resources. Now, a word or two about behavioral health integration, this idea of integrating mental health services into, say, HIV primary care. Heath really outlined the different levels of behavioral health integration very nicely. We can think in terms of a continuum here: coordinated care, co-located care, and integrated care. And we'll talk through what each of these mean. And I invite you all to think as we're going through this about where your system is at, where your healthcare organization is at, where things are at in general in your country or community, and how you can get behavioral health integration to the next level up. So coordinated care typically refers to separate systems and facilities for, say, HIV primary care and mental health services. These two only communicate when it's clearly an issue-driven situation. And we talk about level 1 of coordinated care, which has very minimal collaboration between mental health and HIV primary care. Level 2 involves some basic collaboration at a distance, only in situations where typically there's some kind of crisis does this collaboration occur, and these are not co-located facilities. Then there's co-location as the second kind of stage in this continuum. Level 3 is what we refer to as basic collaboration on site. So these are in the same place. They're in the same facility, but really operating as different systems. So not integrated much beyond that. Level 4 of co-location involves close collaboration on site with some integration of these two different systems of mental health services and, say, HIV primary care. Often this integration is driven more by and comes into play when we have more complex patients with more complex combination of mental health and physical health needs. There is some regularity to face-to-face interactions and a basic understanding of these two different professional cultures of mental health and, say, HIV primary care. And then we talk about integrated care. Level 5 here is close collaboration that approaches a fully integrated practice. It's the same facility, some shared space, moving towards one integrated team, but not quite there yet. And then level 6 is full collaboration in a transformed and entirely merged integrated practice, sharing all the same space in the facility. It's one integrated system of team care with very clear and aligned roles and cultures that are blended across mental health and, say, HIV primary care. Now, another key principle here I just want to touch on is trauma-informed care, which is very important when we're talking about stigma, populations living with HIV who disproportionately have had traumatic experiences and have post-traumatic stress, as I mentioned earlier. So what is trauma? It results from either a single or multiple events or experiences that cause some kind of serious threat, loss, or harm to a person. It really overwhelms the person's adaptive coping skills and have effects that are adverse and last potentially for a person's entire lifetime if not addressed and not treated, and can adversely impact a person's basic social and occupational functioning, as well as their mental and physical health. What's post-traumatic stress disorder? It's a psychiatric disorder resulting from experiences of trauma that occurs in people who've experienced or witnessed a traumatic event like natural disaster, serious accident, terror attack, have been in war or combat situations, have experienced rape or other violent personal assaults. And very importantly here, we've done studies that we published showing this, post-traumatic stress disorder can also occur as a result of chronic stigma and discrimination, even in the absence of the kind of traditional traumatic event I just described. We published a study here in the United States showing that everyday discrimination towards transgender people was associated with full-blown clinical post-traumatic stress disorder, even in the absence of a traditional traumatic event. While this is a population that does experience more violence and assault than the general population, even if that has not occurred, just the chronic daily discrimination, victimization in smaller everyday ways can lead to full post-traumatic stress disorder. And that's true for people living with HIV as well. The experience of the diagnosis and the stigma associated with it can contribute to post-traumatic stress disorder in and of itself. This is a study we did now a decade ago in the San Francisco Bay Area in California with HIV community clinics. And we showed this relationship between post-traumatic stress disorder and worse HIV medication adherence among people living with HIV. We found that people with psychological dissociation, psychological detachment from reality, which is a hallmark of more severe PTSD, that was associated with lower odds of HIV medication adherence. So it's important to think about psychosocial interventions that address post-traumatic stress symptoms to really maximize HIV medication adherence and virologic suppression. There can be ways to integrate trauma-focused treatment services into HIV medication management to optimize adherence, or at least improve it. And there are what we think about as biobehavioral approaches to HIV care. So tailored behavioral interventions for HIV medication adherence, like Life Steps, which was developed at Fenway Health in Boston, where I'm based, by Steve Safran. It's now a Centers for Disease Control evidence-based intervention. And this was developed based on cognitive behavioral therapy to maximize HIV medication adherence for particularly men who have sex with men living with HIV, but can be used more broadly than that, with a very culturally tailored approach based on sexual minority stress frameworks. So we understand now that combining biomedical and behavioral HIV treatment is optimal for HIV health outcomes. And often what we do is restructure these minority stress cognitions to improve HIV-related self-care and health outcomes. So restructuring beliefs to the effect of, it's never going to get better, nobody can be trusted, no one will ever love me, and so on. Important to note that co-occurrence of substance use disorders and post-traumatic stress symptoms is highly prevalent, particularly among people living with HIV. And when these two co-occur, substance use disorders and post-traumatic stress, that's associated with higher treatment cost, decreased adherence, and worse both physical and mental health outcomes. And it's helpful to think about substance use disorders as an avoidance strategy in post-traumatic stress disorder. So when you have a physically inescapable traumatic stressor, it can be helpful in the moment to dissociate from reality so that you don't experience that pain. But if at some point in the future you don't cognitively and emotionally process traumatic experiences, that's what's thought to lead to post-traumatic stress disorder, whereas someone else who had the same traumatic exposure may not develop post-traumatic stress disorder. And a way to numb and avoid processing painful traumatic experiences from the past is to use substances. So fortunately, in addictions treatment settings in the US and around the world, there's increasingly a move towards a more trauma-informed approach. And there are excellent integrated treatments that address both substance use disorders and post-traumatic stress that are well tolerated and improve both substance use disorders and PTSD, like an intervention called Seeking Safety that we've implemented in the United States for people living with HIV. So it's helpful to think about your facility, and if it's a trauma-informed organization, a trauma-informed service organization is one that realizes the widespread impact of trauma, understands potential paths to recovery, recognizes signs and symptoms of trauma in clients and staff, as well as anyone else who interacts with the system, and responds by fully integrating knowledge about trauma into all of its policies, procedures, and practices, and seeks to actively resist re-traumatizing anyone who interacts with the system. You want to think about how you can have a trauma-sensitive practice environment, training staff to ensure that all clients have a sense of safety in their interactions with staff, including both clinical and administrative staff, identifying how trauma can act through certain mediators like lack of adherence to treatment recommendations or substance use disorders, for example, and educating clients about the connection between trauma and adverse physical and mental health outcomes. Most people don't realize that they have post-traumatic stress disorder, and certainly tend to not realize that their post-traumatic stress disorder may be contributing to their suboptimal adherence to HIV treatment recommendations, for example. So that education piece is important, and really thinking about linkages to suitable resources and referrals if more specialized post-traumatic stress disorder treatment is needed. Prior traumatic experiences can reduce the likelihood that people will seek care, that they'll trust caretakers. So trauma is associated with a lot of mistrust of caretakers and systems of care. And important to know that to retain our clients in HIV care, many of whom have trauma histories, we need to engage them with consistent collaboration, transparency. We need to earn trust and adopt a consistently supportive stance. We really emphasize training all staff to mitigate the adverse impact of implicit bias. These are negative beliefs we may ascribe to a particular group of people that is very connected to stigma, whether it's people living with HIV, LGBTQ people, and these implicit biases that we're not even fully aware of can adversely impact our communication with clients, our rapport with clients, and our decision-making. So we do a lot of work with case-based scenarios to train staff so that they become aware of the fact that we all have implicit bias, that this is something we can gain more control over, and we can do so to improve our communication, our rapport, and our decision-making. Bias will come through even in our nonverbal communication, our facial expressions, our mannerisms, and clients are smart and sensitive and will pick up on this. So we really need to do some hard work internally, all of us, to become aware of our own implicit bias, the stigma we may enact towards other people, and to gain more and more control over this. And these are some examples of tools we have through the National LGBTQI+ Health Education Center that are case-based, and all these are available for free to download from our website, and I'll provide that information at the end. Now, a final word about LGBTQ communities. What are some minority stress-related care principles we can use? And as we know, LGBTQ communities disproportionately are living with HIV across the globe. We can normalize the adverse impact of minority stress. So people will often attribute challenges in their lives to personal failings rather than to external stigma and discrimination. If we can name this external stigma and discrimination, that can be very liberating for people to be able to correctly discern when challenges in their life are due to stigma and discrimination and not due to a personal failing. Facilitating emotional awareness, emotional regulation, and self-acceptance, some of those pathways in that stigma and minority stress framework I showed earlier. Empowering assertive communication. For better or for worse, people living with HIV, LGBTQ people have to be advocates for themselves in healthcare and in life. So we help people engage not in passive communication, not in aggressive communication, but in assertive, effective communication to get their health needs met. Restructuring some of those minority stress beliefs, like it's never going to get better, nobody can be trusted, no one will ever love me. Validating unique strengths of LGBTQ people. This is a population with enormous resilience that's overcome tremendous obstacles, achieved greater and greater integration into the mainstream fabric of society in many countries. So if we can help particularly younger people feel connected to that resilience, that can be very empowering. Fostering supportive relationships and community with LGBTQ people and beyond, and affirming healthy and rewarding expressions of gender and sexuality. We have many resources at our website, lgbtqiahealtheducation.org, webinars, best practice guidelines, interactive learning modules that we just revised and launched. All of this is for free, and you can use this to train yourself and your staff. Finally, we really think often in terms of mental health and people living with HIV about how to promote and expand a person's resilience. What is resilience? It's the ability to bounce back or rise above adversity at an individual, family, community, or provider level. Beyond individual characteristics of hardiness, resilience includes the process of using available resources to negotiate hardship and/or the consequences of adverse events. And our Substance Abuse Mental Health Services Administration in the US has these wonderful strengths-oriented questions to promote resilience. For example, you can ask people, what would you say are your strengths? How do you manage your stress today? What behaviors have helped you survive your traumatic experiences? What are some of the creative ways that you deal with painful feelings? What characteristics have helped you manage these experiences and the challenges they create in your life? How do you gain support today? What does recovery look like for you? Now, I really appreciate that everybody filled out the questionnaire, the survey that Bruce sent out to leaders and participants from various countries participating in the Learning Collaborative. And we had some very interesting information that people shared about the availability of mental health services right now for people living with HIV. So I just wanted to quickly highlight these. And first, I'm going to go in alphabetical order. Here are the results from our respondent from Cambodia. We asked about whether there's access to licensed mental health staff at most health HIV programs. Our respondent said no. These exist as independent, separate, specialized services in most hospitals. What mental health professionals are typically available? They said always psychiatric nurses, counselors, and non-psychiatrist physicians trained in basic mental health, often psychiatrists and social workers, rarely psychologists. Are community mental health workers routinely available? They said no, though there's recent training for staff, mostly nurses at 300 health centers for counseling and referral. Is mental health screening routinely conducted in HIV care? We were told no. Are mental health services routinely integrated in HIV care or obtained by referral? They said there's a pilot of HIV and mental health service integration currently underway, and this should be complete in the next 6 months and will be expanded if it's successful. Who prescribes psychiatric medications? They said psychiatrists and physicians trained in basic mental health, psychiatric nurses if there are no physicians available. Are emergency psychiatric services readily available? They said yes at some hospitals. There's only one hospital with an inpatient psychiatric unit that has 10 beds. Our responses from Lao. We asked about licensed mental health staff at most HIV programs. They said this is the case in central and provincial hospitals, not in primary healthcare centers. What mental health professionals are typically available? Often counselors, sometimes psychiatrists, psychologists, and psychiatric nurses, not often social workers. Community mental health workers, are these routinely available? Yes. Is mental health screening routinely conducted in HIV care? No. Is mental health services, are these routinely integrated in HIV care, or are they available by referral? They said by referral. Who prescribes psychiatric medications? They said only psychiatrists. Are emergency psychiatric services readily available? They said only in urban areas. A respondent from Malaysia, with regard to licensed mental health staff at most HIV health programs, they said yes at all hospitals and health clinics. What mental health professionals are typically available? Hospitals always have psychiatrists, psychologists, and social workers, as well as counselors, less often or never at health clinics. Community mental health workers, are these routinely available? Yes. Mental health screening, is that routinely conducted in HIV care? Only if indicated during follow-up. Are mental health services routinely integrated in HIV care or by referral? These are routinely integrated and by referral to a hospital if necessary. Who prescribes medications? Psychiatrist, any physician or family health medicine specialist. Emergency psychiatric services readily available. They are in clinics with family health specialists and at hospitals. Our respondent from Thailand said that licensed mental health staff are not present at most HIV health programs. They may be present in some tertiary care hospitals. Counselors are always often available. Psychologists and social workers sometimes. Community mental health workers are routinely available. Mental health screening is not routinely conducted in HIV care. Mental health services are integrated in HIV care. They are not actually. So if this is triggered during a clinical session, a client can be referred out, but we were told in the respondents' words, this is hardly successful. Who prescribes psychiatric medications? This is through task sharing initiative that certain psychiatric medications can be prescribed by HIV doctors. And our emergency psychiatric services readily available, mainly through emergency rooms at any hospital. Finally, or not finally, two more, almost done. Thank you for bearing with me here. Our respondent from the Philippines, licensed mental health staff are available for tertiary hospitals, not for primary care centers. Mental health professionals that are available, tertiary hospitals often have psychiatrists, social workers, and counselors, sometimes psychiatric nurses and psychologists. Community mental health workers are not routinely available. Mental health screening is not conducted routinely in HIV care. Mental health services are available if warranted. Who prescribes psychiatric medications? Physicians with an S2 license. And emergency psychiatric services are available in tertiary hospitals. Finally, our respondent from Vietnam said that licensed mental health staff are only available at district health center and higher levels. Psychiatrists are always available in these settings, sometimes psychologists, psychiatric nurses, and social workers, as well as counselors. Community mental health workers are not available. Mental health screening is not routinely conducted in HIV care, except in methadone and buprenorphine clinics and addictions treatment. Mental health services are integrated in methadone and addiction treatment services, or in the form of methadone and addiction treatment services that are integrated in HIV care. Psychiatrists are the ones who prescribe psychiatric medications, and emergency services are available in mental health hospitals at all provincial and central levels. So with that, I will stop. I think I may have gone a few minutes over. I apologize to all of you and to Bruce, but happy to answer any questions, or if we don't have time, happy to move into our breakout groups. And I have the questions here for that as well.
So actually, Alex, so thank you. That was great. And I think really addresses a lot of the really fundamental issues that have come up again and again in the countries about stigma and mental health. Not surprisingly, there are a number of questions in the chat, which I'll go over. And I think we should take the time to do that, and then we'll do breakout groups afterward. I just wanted to say that, again, this topic came up more than once when we asked countries about issues they wanted to discuss. So I'm not surprised that we have a lot of questions. So the first question is from Dr. Anita from Malaysia. How can we differentiate efavirenz related mental depression from other depression?
It's a great question. Qualitatively, they're not adequately distinct that you could recognize depressive episode from efavirenz versus a depressive episode that's not. So in theory, the only way you would really know is if you were to stop the medication and see if that leads to depression improving. Either way, the good news in a sense is that the treatment would be the same. So you would, if the person has depression, you would treat it regardless of the cause, or you would attempt to, if that's a medication that the patient needs to stay on. So unfortunately, there's no way to distinguish it, but the good news is that the treatment would not differ either. So thank you for that great question.
Great. And then from Ivy Hapitan from the SHIP Clinic in Philippines, can you give an example of trauma-informed care modality that's effective when providing support to people with HIV and LGBTQ populations, like for PTSD? Is there a specific type of therapy that works?
Absolutely. And I thought about covering that today. I knew that we wouldn't have time, or I'd have had to cut something else. I otherwise, typically do a whole training on cognitive processing therapy, which is an evidence-based treatment for post-traumatic stress disorder that was developed for survivors of sexual assault. And every Veterans Affairs facility in the United States that provides healthcare is required to have a cognitive processing therapy therapist, and over 99% of them do. And this has been implemented around the world for people with post-traumatic stress disorder. It is a manualized treatment protocol that involves education about post-traumatic stress, that involves developing an impact statement, which can be written or oral if there's a literacy barrier, that identifies the ways in which past traumatic experiences have altered the person's beliefs about themselves, about other people, and the world around them in several domains that include power, safety, trust, intimacy, and control. And it addresses some what we call cognitive distortions in cognitive behavioral therapy, or what are called stuck points, cognitive processing therapy, rigid beliefs that come from having traumatic experiences that can be reframed in a way that increases cognitive flexibility, agility, and reduces emotional distress. So that's one excellent evidence-based treatment that is increasingly implemented around the world. And we've implemented that for people living with HIV through the Ryan White HIV/AIDS program in the United States. Another, just one important thing that is a trauma-informed approach, for example, when doing a physical exam in an HIV care setting, is to always ask clients permission to conduct a physical exam before you do it, to explain to them each thing you're going to do in the physical exam before you do it, so that when you make physical contact with them, you're not triggering them and re-traumatizing them. You let them know that they have permission to tell you to stop at any point. If they want to have someone accompanying them during the physical exam, to enable them to do so. For transgender and gender diverse clients, for example, and generally for everybody, you could ask them how they refer to their body parts and to reflect their own language back. For example, transgender and gender diverse people, or transgender men, may refer to their chest and not their breasts. So you want to ask people how they refer to their body parts and reflect their own language back. So those are some very concrete, practical, trauma-informed approaches for a physical exam.
Thanks very much, Alex. And we'll have to have you back to talk more about cognitive, the interventions and I'm sure there are other things that will come up too. So question from Harry that was also reflected in questions from Vieng, from Chazzy in Lao. As mentioned, NGOs should start to provide support for those who have mental health issues. And what would you recommend would be the best ways for community-based organizations or community-based health workers so that they can carry out a survey and get information to provide support for mental health issues? So yeah, I think that's the question.
Yeah, it's a great question. And we initiated something similar in my work with PEPFAR and HRSA in Uganda. And the most important and helpful thing to start doing is to implement this very basic screening for mental health problems in community care settings. Because once you start screening, first you'll very quickly see the prevalence of, for example, probable depression in your community setting and among the clients that you serve. And that gives you a sense of how to design and on what scale to implement either in-house treatment and care and counseling for depression or emotional distress at a basic level, and community health workers can be trained to do much of that basic counseling, or to refer out. So in terms of a survey or understanding what the community needs are with regard to mental health, the most efficient and effective way to do that is to plan to implement systematic screening with, for example, the PHQ-2 and PHQ-9.
Great, thanks, Alex. And then from Angelo in the Philippines, complimenting you on the presentation and tools. Do you have any advice or examples on how family members, caregivers, and partners of people with HIV and key populations need to be capacitated on addressing stigma and discrimination and to manage potential for existing mental health issues for both people with HIV and at-risk groups?
Absolutely. I think it's incredibly valuable to provide education for families and communities about stigma and mental health in a very simple way. So it's very helpful for people to understand that living with HIV, being an LGBTQ person, can lead to a lot of mistreatment in society, because these are things that are not often accepted fully within society. And that mistreatment can come in many forms and can be very upsetting and cause a lot of harm to the mental health of the person who experiences that mistreatment, that discrimination and stigma. And we can advise in a very simple way families and communities to adopt a very supportive stance, and to understand that if their loved one or community member is behaving in ways that they don't completely understand, or seems withdrawn, or is becoming angry at times, that this is something we can try to be patient with and supportive around. It's the result of a lot of mistreatment and pain that the person has experienced. So I think this sort of explanation can be very helpful. And sometimes it's about having that conversation several times with family members or community members for them to adopt a more supportive stance. Even if they do so in some ways, it can make a very big difference for the person who is suffering within that community.
Thanks. We have a question from Cambodia, Dr. Bora.
Yeah, thank you, Alex. This is the Cambodia team here. I'm Bora. I just want to know around that you explore the data and the information from Cambodia, Laos, Thailand somehow. And actually, I just roughly that situation is like different. Like I example in Cambodia for HIV program, we have used the tool that we call K10 somehow that measure the mental health problem. But I'm not sure that this kind of tool can apply the same way for measure on that or not. As I know from the Cambodia, we have a mental health department have another tool that can deeper, measure of the mental problem more than that. But for HIV program, we still don't know how that kind of tool that very good for use is that. Can you give the idea of which tool that used to measure this kind? Thank you.
Sure, thank you for that question. I will say there isn't just one tool that is helpful. There are a number of tools that are helpful. I use the example of the PHQ-2 and PHQ-9 here, which is used globally for in HIV care programs or by Ministries of Health around the world. I've seen this implemented for people living with HIV in, for example, Jamaica, Uganda, and India, among others. And you know, I think that it is implemented in parts of Asia as well. But it's not the only possible tool. So I would love to see what it is that's being used in Cambodia that you described, but there's a very good chance it's also a helpful tool to start with. And I think more important to do any kind of mental health screening than to not do it because we're trying to have the perfect mental health screening tool. So I think whatever it is that you're using, if you're starting that practice and people are using it and clients are responding well to it and the staff are finding it comfortable to use, that's excellent. And I'd be happy to see which one you're using. I wonder if what you're referring to is the Kessler scale, which is a measure of psychological distress, but I'm not sure. And that's actually a good validated tool as well.
Thanks, Alex. It was really a wonderful presentation, and I think obviously touched on a lot of concerns that folks have, and hopefully we'll have a chance to continue dialogue with you. Any last questions before we transition into the breakout groups? Okay, so before we talk about the questions, and Charlie's going to introduce the breakout sessions. I wanted to remind people that the first thing to do when you get into your group is to assign a group facilitator to lead the discussion and a rapporteur to report back at the end. So please don't forget to do that. And we will pop in just to make sure everything is going okay. So Charlie, let me kick it back over to you.
Okay, great. Thank you. So at this time, I am currently pasting the questions into the chat box in both English and in Thai. And I'm going to share a quick guidance PowerPoint so folks can be aware of the process. 1 second. Alrighty, so each attendee has been pre-assigned to one of 6 breakout groups. Just know that you may be moved to a different group depending on the active participation and attendance of each group. This could happen in the first few minutes as you enter the group. One network meeting representative will check in with each group during the first few minutes. I just pasted the questions into the chat, but I'll also provide them on the next slide in both English and Thai. So I ask that you please screenshot the slide or copy the questions from the chat. The breakout session will run for about 30 minutes. I will provide 10, 5, and 1 minute warnings before the session ends, so you're aware. The report back will last about 15 minutes, so please be concise and summarize key points in just 1 to 2 minutes. Like Bruce mentioned, during the first 5 minutes, please agree upon a facilitator and a rapporteur. So the role of the facilitator, like Bruce mentioned, is to ensure that the group address each question, while the rapporteur will scribe notes and briefly summarize key points during the report back. So here are the questions. I'll read them quickly. These are the questions in English. What mental health issues are you finding among key populations living with HIV? Number 2, what mental health services would you like to have available in your facility? Subpart to this, how can these services be made KP friendly? What resources would you need to provide these services? Question 3, what specific mental health interventions could be developed to support populations? And the last question, what is the availability of crisis response interventions? Those are the questions in English. Here are the questions in Thai. I will ask that you please screenshot this so that you can reference them during your breakout session and so the facilitator is able to move to each question.
Charlie, I thought you were going to impress us all and read them in Thai.
Maybe next time. Okay, I think that's good. So I'll stop sharing my screen now. Is there anything else, Bruce, that you'd like to mention before we begin?
No, we have, probably there'll be some close to 40 people in the breakout groups. So, so there probably will need to be a little bit juggling as we get going. So.
Alrighty, so I'm going to begin the breakout assigning process. You shall be placed into your breakout room. Best of luck. We'll see you in about 30 minutes.
Okay, well, I want to welcome everybody back. I gather that there were some pretty interesting discussions happening in the breakout rooms, and really looking forward to the report back. So I think in the interest of time, let's go ahead and start off with group number 1. I don't know, Charlie. I don't know who's like which group and stuff. So I closed out my list for some reason. So by mistake. So
looks like Dr. Anita's group, who is the report back person.
Great. Who is the report back? Ah, okay, great.
Oh, wow.
And with the PowerPoint, way to go. Okay. But we're not hearing anything, and you might be on mute. Still not hearing anything?
Good morning.
There we go. Okay, hi.
Good morning. I'm Nurse Rodan from the Philippines, and these are what we gathered in our group presentation for the group 1. So the first question is, what mental health issues are you finding among key populations living with HIV? Basically, on the Philippines and in Thailand, we gathered some of the most common mental health issues that we are experiencing with our patients is depression, self-stigma, treatment fatigue. We have a lot of patients who are lost to follow-up and lost to care because they are experiencing treatment fatigue in taking their medication. Some of our patients are having a suicide or self-harm, either intentional and unintentional. And also we have diagnosed some of our patients to have a bipolar and multiple personality disorders. We are seeing them in our clinics back in the Philippines and in Thailand. For the next question, what mental health services would you like to have available in your facility? First, we focusing on the counseling, specializing our special groups that need to be trained, like a key population-led clinic and groups who are focusing on counseling their peers. And most of the peers must be trained on sexual orientation, gender identity, and expression. And also, we want to have a one-stop shop for HIV treatment and also integrating mental health services in our clinics. So we need to have a one-stop shop catering for mental health services and HIV testing, treatment care, and support for all our people living with HIV. And also we want to provide quality mental health services, especially for the key affected population, which also we want them to leave the clinics in order for our patients to be more comfortable in doing their visits in the clinics, to have key population-led services. And what are the resources that we need to provide these services? We want a training, a specialized training for the healthcare workers and the key population who are trained on the management on both HIV management, mental health management, and other LGBTQI issues and concerns, and SOGI. Next, for the number 3, what specific mental health intervention that could be developed to support the key population? We identify first to intensify the diagnosis of the mental health illnesses and acknowledge it on an early stage. We need to develop our skills on acknowledging what is nearly sad state of a person versus the depression, because not all of us are psychiatrists and not all of us healthcare workers are psychologists. So we want to intensify the diagnosis in order for us to address their issues and concern. And because we believe that if depressions we neglect the depression, it may lead to suicide and other most mental health issues and concern that our patient may experience. And also we want the key population-led counselors, especially for our key population-led clinics. We need to train key population and staff on the management, not only with HIV, but also with the mental health management. We also want to provide an online teleconsultation and 24/7 hotlines that can provide services for the patient. Although, especially with this pandemic, with this time that the patient can do teleconsultation even on their house without going to the clinics. And also we want to provide a hotlines in order for us to call anytime that they need services for their care. We also want to provide the psychosocial support hotlines or a crisis center in order for us to update all the in order for us to give the services that the patient need, and also a consolidation of all hotlines that can help all walks of life, from pediatric, from mental health, from HIV and other concerns that our patients are having. And the last is for the question number 4, what is the availability of crisis response intervention in our facilities? In the Philippines, it is still on process to conduct or to provide crisis hotlines, but in the meantime, all the issues and concerns of our people living with HIV are managed by their respective treatment hubs, because our patients are enrolled per facilities, and all the facilities are the one who each managing all the concern, especially with this kind of pandemic that we have our clients from far-flung areas, and the facilities are managed to provide their medication, to bring the medications to the houses of our patients. And in the country, when we talk about mental health issue, the biggest hospital, the National Center for Mental Health in the Philippines, are establishing and providing a crisis center hotline for mental health emergencies. And anyone, you can search this online, and they can do an appointment or online counseling by the facilities. In the case of other crisis problems like losing their jobs during this pandemic, we do not know where to refer specifically. And the crisis response team in Thailand, they are able to establish a crisis response in Thailand addressing the stigma and discrimination and also other issues and concerns, especially for if there sometimes an abuse from the authority, they can report to the said crisis response team. And also currently we are having a specific crisis response, specific concerns that was established per country, but there is no integrated complaint crisis center. Although in Thailand and in Malaysia, they have complaint crisis intervention center, but we want to have one-stop shop integrated management center for all, especially for our people living with HIV and their other concerns. I think that's the end of our presentation for the group 1. Thank you for listening.
That's great. Sounds like you had a really thorough discussion, and really appreciate all of that information. I don't know if we're going to have time for questions, but I want to try to get through all the group presentations. So let's move on to group 2.
Hi. Group 2, we had representatives from Cambodia, Laos, Malaysia, and the Philippines. For question 1.
Sorry, and group 1, you can stop screen sharing. Thank you.
What mental health issues are you finding among KPs? We had financial stress leading to mental health issues. KPs try to protect themselves from the general population for fear of stigma. Depression, rejection, and issues with partners, about how to explain their HIV status to their partners. Question 2, what mental health services would you like to have available? Assessment and screening for mental health, readily accessible mental health experts, the need to design a strategy for assessment and screening of mental health issues, and to collaborate with the mental health unit to design a screening tool customized for KPs. It would be good to educate KPs about mental health issues and linking patients to services. So cooperation, collaboration with the mental health unit is key for that. And to make sure physicians are trained on assessing and linking the patients. How can the services be made more KP friendly, making sure that KP patients are linked to KP oriented providers? And what resources would you need? Time and staff to do this, and collaboration with the mental health program. What specific interventions could be developed to support KPs? The Philippines uses the Beck's Depression Inventory tool, which they find helpful. And also to make sure services are KP friendly and to utilize virtual counseling as much as possible. Availability of crisis response interventions. Lao has a hotline, but only for HIV services. Cambodia refers mental health, severe mental health cases to a mental health center, but they need to integrate the mental health into HIV services. That's what they want to do. There's one KP friendly service center, and that model needs to be spread to other sites. Malaysia has a hotline, a national hotline for mental health issues, and the Philippines has a mental health unit hotline and provides psychological first aid and psychosocial support to HIV patients in the clinic. And that was group 2.
Great. Alex, do you want to just, oops, okay, Alex had to sign off. He's got a really early morning appointment. So just wanted to, I was going to ask if he wanted to say anything before he left, but he zipped off. So, okay, thanks, Richard. Group 3.
I'm sharing my screen for Ivy.
Thank you so much, Charlie, for sharing your screen for group 3. Just a quick shout out to my group mates, Sudara Chan from Cambodia, Shara Sala from the Philippines, and for Harry for helping us facilitate our conversation. And hi, everyone. My name is Ivy. I'm from the Philippines. I will only walk you through the ones that have not been mentioned by the first 2 groups because I think they already discussed a lot of the questions here very comprehensively. For the first one, the common answer is anxiety and depression. But for grief, we notice that there are different types of grief, like losing a job, change in lifestyle, loss of a loved one. So there's a lot of grief that goes beyond death when we speak of anxiety and depression. There's also a lot of guilt and shame. For example, if someone engaged in chemsex or other risky behaviors. We've also noticed some risky behaviors or poor coping mechanism that resulted in risky behavior such as unprotected sex. Cambodia shared that many of their patients feel very sad in terms of accessing services because of the lockdown. A very similar situation here in the Philippines, and of course, loss of income, whether it's from small or large businesses. So then that takes me to number 2. What mental health services would you like to have available in your facility? Definitely, we wish for more access to affordable licensed clinical psychologists and psychiatrists, innovative suicide watch in collaboration with family members, caregivers, and the community, and to remind or educate clients that they don't have to be in complete and utter despair or in a desperate state before asking for support. We're hoping for a more institutionalized or a national cascade when it comes to effective mental health support with proper budgets in place, trained healthcare professions, and also training for the people on the ground. And that includes a lot of caregivers, such as family members, friends outside of the healthcare facility. A general hotline, which was mentioned by the first group, would be very, very helpful, especially if they don't really need a psychiatrist or a clinical psychologist. A hotline that is safe, unbiased, objective support. More importantly, a hotline wherein someone answers the call 24/7. For Cambodia, availability of mental health services in the ART facility, because it is costly to avail of these services outside of their facility. An example would be a session might already cost $50 US, and this is no longer accessible for the general population. So they hope for accessible counseling services and affordable medication in the facility itself. How can these services be made KP friendly? Language and communication can be inclusive, invitational, and interoceptive or reflective. Having some focus group discussions or one-on-one needs analysis so we can engage more from key population when it comes to them freely giving us feedback without worrying about the quality of treatment, care, and support they will get. We would like to have more research or evidence-based driven services, and just, the general vibe of having friendly and accommodating and very open like facilities and support. What resources would you need to provide these services? Government or institutionalized support, such as having budget for public hospitals, LGUs, and other community-based organizations. Outside of governmental support, perhaps we can also use evidence-based data to advocate for resources to inspire movement outside of the government, such as corporate social responsibility, private sector, and inspiring more community support. What specific mental health interventions could be developed to support key populations? Having MH profession in the facility trained in trauma-informed care to support people living with HIV and LGBTQ populations. Group 1 was able to emphasize this, so I won't go through it anymore. Last one, what is the availability of crisis response interventions? In the Philippines, we do have PLHIV Response Center. I'm not sure if Dr. John is still with us, but I think his network is very much involved in this. So thank you, Dr. John, if you are still in this Zoom call. We also have crisis lines or 24/7 emergency hotlines. The barrier for this is not everyone has access to a phone or, like a budget to pay for their monthly load. So I don't know if there's any kind of innovation that can still be done when it comes to hotlines. Thank you.
Great, thank you, Ivy. Really appreciate that, also that thorough summary as well. I'm going to ask Group 4 to join, and like Ivy, if you wouldn't mind, you don't have to report back on things that have already been said in the interest of time. So if I can turn it over to whoever from Group 4 is going to present.
Yes, hi, it's Margaret Jasmine reporting on Group 4. I'm sorry I don't have a support. I was chosen last minute. So I think for question number 1, we have about the same answers. So mainly depression, anxiety, suicide risk, and particularly among MSM and transgender population. Second question number 2 about the same. Having a psychiatrist on site for a lot of us, as access is really difficult. That's the example for Haiti, and there's a lot of stigma around mental health. Also peer learning, peer-led intervention and support groups. So how can the services be made KP friendly for facilities who are not KP oriented? We suggest to have training for providers to reduce stigma and also help them, empower them to assess mental health issues. resources, same human resources, of course, having the budget to support that. What specific mental health intervention could be developed to support key population? We mentioned training, education of the community, and having support group and capacity building for KP population. So one positive experience shared for Haiti, we had our first consumer involvement training for KP that will empower them to have their voice heard in decision making at facility level. Also having those support group in the community and those networks. What is the availability of crisis response intervention? Mainly for all of us, it was hotlines. And of course, there are those issues already mentioned with connectivity and accessibility. But that's what is we have now, and we will need to have a stronger HIV response center.
Great, thank you so much. Okay, so now we will move on to, I lost track of count. That was group 4, right? So let's hit group 5. And again, just to try to hit the high points that have not already been covered. Do we have anybody from group 5? Okay, there we go.
Good afternoon. So I am Roland from the Department of Health, National HIV Program from the Philippines, and I will be presenting for group number 5. For question number 1, I think it's common. It's usually common across all the countries. So we have depression, stigma, and discrimination. But in the Philippines, we would like to highlight that there's also treatment fatigue and suicidal tendencies among our PL-HIVs. So it's a common concept for all countries. As to question number 2, VM from Laos specified that there is no specific HIV counselor in Laos. So there's no specific HIV counselors. But in the Philippines, we have the presence of our peer counselors and community-based mobilizers. So he also emphasized that there is a need for a mental health facility to address stigma and discrimination in Laos. And also there's a need to provide strategic management training for counselors to empower them and motivate PL-HIVs to access for treatment, because they have noted that they have lost to follow-up cases in Laos. And for as to the resources, he mentioned that there's really a need to provide technical assistance to for a resource person to provide professional counseling training, because in Laos, he mentioned that the trainers are usually of the belongs to the education sector and not really professional counselors. So there's a need for technical assistance for resource persons, and let community people mobilize and be provided with technical assistance. As for the Philippines, the approach is usually generalized, as mentioned by also some of my countrymen. But I like to emphasize that there's a presence of peer counselors and CBMs. And particularly, there's a need for targeted mental health programs for young key populations, MSMs, and PWIDs, particularly in Region 7 of the country. So for question number 3, there is a need for targeted services for PWIDs and FSWs in Laos. For the Philippines, the main drivers are YKPs or young key populations and MSMs. For question number 4, we mentioned that crisis management is not available in Laos. There's really a problem on mobility and financial support for PL-HIVs. As for the experience of the Philippines, we have telehealth hotlines 24/7 and the HIV Access Network, as mentioned by Ms. Ivy earlier. So the Department of Health also has included crisis intervention provisions on the HIV adaptive plan for COVID-19 crisis. So there will be crisis intervention provisions and also the need to utilize other means to offer undisrupted HIV services during the event of a crisis. Thank you very much.
Thank you very much for that thoughtful and concise presentation and underscoring the things that are, that stood out that were different. And then last but not least, group number 6.
Right, so this group 6, so I'd like Greg, who has volunteered to do the presentation for our group. Go ahead, Greg.
Okay, thank you. A big thanks to Angelo for documenting our conversation. He did a really excellent job. Things that are different for the first question, mental health issues are not really any different from other countries, although I think in Thailand that we have found that the issue of self-harm, suicidal ideation has actually been reduced over a number of years as treatment, access to various other services become more available. The one issue that we are seeing as maybe an obstacle to this is that on the one hand, we see the need for greater screening of mental health issues in the services, but at the same time, we have the call for expedited services for key populations and also for the diversified service delivery. And in these service formats that oftentimes that the mental health screening often is the service that gets cut away from the larger service. So this is an issue that we need to find a better balance. For the mental health services that we would like to have, I think like others that, having proper appropriate training for lay providers, either that or having, a direct service within the service that is available. Oftentimes, even in the government hospital services, private services, and then also the community-based key population-led health services, everything is based on referral. And there's not really a tracking system that will allow us to look at the success. For the mental health services, also related to the training, that I think all staff need to have a background in SOGI, diversity, and also stigma and discrimination. This is often not included in some of the training. And also, I think we need to look at what used to be part of, say, the regional training here in the Asia Pacific region, was looking at the exploration of service provider attitudes, values, and biases, and how we manage these in service provision. It used to be provided, but I think as resources have been a bit more constrained in recent years, that this is also something that's been cut away from training, but very important in relationship to stigma and discrimination and other mental health issues. For the third question, specific interventions, I think that particularly for lay providers, that we can do more in building their capacity, particularly providing some basic intervention, not just only the screening. And one method would be providing basic cognitive behavioral training in basic cognitive behavioral therapy. I think we also need to distinguish between, what interventions can be provided at a more mental health professional role versus lay provider role. I think in some of our countries, there's very distinct roles that have been distinguished in professional medical councils or by government policy, which perhaps prohibit the provision of certain services. So those need to be re-examined. The availability of crisis response interventions, I think like the other countries, a lot of hotline services, but we found that in the countries in our discussion, oftentimes they are time limited, sometimes not available. In the case of Thailand, there's also the availability of kind of self-screening tools then linked to services, but then the linkage between the self-assessment and then getting a response from either a hotline counselor or a public service provider may not be very expedient. I think there are also other, again, looking at how we make our linkages and how formalize the linkages to the emergency crisis services need to be made. I think there's a lot of confusion. There are services available, but then how do we make the link? How do we make the referral? Is often very unclear under some circumstances. And then we also need to look at kind of out of the box, perhaps support services such as halfway houses, and also maybe broader services that, say, for example, the psychological medical services in the hospitals, that they may not only provide maybe direct mental health services, but services linked to drug use, rehab. So I think there are opportunities we need to maybe explore and confirm the services that are available and our linkages to them and the linkages between them. Okay, so just very in brief. I hope I reflected.
No, that was a lot. There was a lot. Thank you. And I think I realized as we listened to each group, we could have really spent the whole meeting just talking about mental health. I think what we will do is on our side is we will go over all the report back that you've documented, and I'll ask those who verbally presented to share notes with us, and we will synthesize that. I think there are going to be some key themes that will pop out from here related to recommendations and an agenda essentially for addressing mental health across the continuum of health and supportive services, community and medical sides. I think, we didn't really get into issues related to drug users today. There were a lot of things brought up about learning more on how to respond to trauma-informed care and PTSD, clarifying roles of community workers and medical psychiatrists. There are many different issues to unpack. So I really want to thank all of you who contributed to the rich discussions in the breakout groups, and a shout out to Alex and Absentia for really a great talk and overview. Before we formally close, I want to say a couple things, and then we're going to float up a quick poll. But I first of all want to thank all of you for for spending the time and the thought and the great presentations over the past 3 sessions. I really enjoyed the guest presentations, and I hope that we'll have opportunities to continue those discussions. This is the first time we really were able to get feedback ahead of time on topics that you wanted to hear about, and we will be following up as we plan future agendas as well, to really identify the topics and then guest speakers, I think, who would be great for the session. So I think our next network meeting will probably not be until after the end of this year, calendar year. And as we usually do, we try to slot it in between those holidays and the Tet holiday in Vietnam. So we'll be looking at dates and trying to come up with that. Whether or not we're able to travel a little bit more, I think is uncertain. But I think it's pretty clear that we now have the ability to run a hybrid meeting. If we do, we can capitalize on the virtual technology. And again, just really want to thank you. Also want to particularly thank Charlie for all of his organizational and management work behind the scenes. You really did a great job. Thank you. And the whole planning team, Richard, Belize, Harry, and Quentin, who, like Belize, joined us at 3 a.m. in the morning on their side. And one of the reasons he left early is that he had to get a few hours before his little kids got up to go to school. So I think it's just was really a great series of sessions. And last but not least, it's really been fantastic to see the progress of the work that you're all doing and keeping it going in spite of COVID and adapting to COVID. And I think the word again here for all of you is also resilience in terms of keeping the services and the advocacy going and focusing on doing the right thing for the people that we serve. Also, quick thanks to both Gilead and ViiV for their ongoing support. And with that, I will turn it over to Charlie, and I say farewell to all of you. We will be in touch with all of you as always, but Charlie will put up the poll and formally close the meeting for us.
Great. So I'm about to launch the poll with 3 quick questions. If you could please answer them before you exit the meeting. This is my first poll, so let's hope it works. Okay.
Oh, I see you have, okay, we can scroll down and see all that, okay. Okay, I guess I said I wasn't going to say anything else, but I'll say one more thing, which is just that if you have any other thoughts about the meeting or feedback, please don't hesitate to write to us, any of us on the team, and we'll appreciate any further feedback. So Charlie, let me turn it over to you to close. Yeah.
Okay, looks like we have 20 respondents for each question. There are about 30 people in the meeting, so I'll let a few more folks
minus
respond.
us. Yeah,
minus
yeah.
us 5, so maybe there's 8 left, but I think some folks are dropping off. So I will just say thank you all so much for your participation, and I will be writing up, a meeting report summary. So I'll be in touch with many of you as I summarize your presentations and might have some follow-up questions. So you'll be hearing from me. But I hope you all have a great rest of your day and a wonderful weekend. And please answer these 3 questions before you depart the meeting. And I'll be here with Bruce and Richard as folks head out. But thank you all so much.
Thank you.
Thank you.
Thanks, everyone.
Bye.
Take care.
Have a good weekend.
Thank you. Thanks,
Thank you,
everyone.
Bruce. Thank you, everyone.
Okay.
Thank
Thank you,
you
everyone.
very much.
Thank you, everyone. Bye.
Bye now.
Thank you.